the endoscopic view as well as the room view. We can
Okay.
see.
Okay, good. Good morning, everyone.
Good morning.
Morning.
So I want to thank Dr. Mustafa Ibrahim for this meeting, the ROEYA team, the Boston Scientific, the Fujina, and the RB. So let me introduce my team. We have the two nurse anesthesists, Dr. Kamal Saidi. The nurse will help you today is Haifa and Meher. My friend, Aymandi colleague, Dr. Hajar Turki, will assist me if any question. So let's begin with the case now. So it's a 68 years old man who presented in January 2021 with abdominal pain, septic shock, and cholangitis. CT scan showed locally advanced pancreatic mass and CBD dilatation. So the plan was emergency ERCP, biopsy, and a plastic stent was inserted, a 10 French, 5 centimeter. The patient unfit to surgery, either chemotherapy. So 3 months later, he comes with abdominal pain, altered liver function test. The CT scan and ultrasonography showed CD dilated and growth in the mass, the head of the pancreas. So the plan today is to exchange the plastic stent with a metallic one. So before the beginning of the transmission, we retired the plastic stent. Now we are near the papilla.
Dr. Sami, how you
Yes.
remove the plastic stents? How you remove it?
Yes, of course. We take off the plastic stent with a snare, a 10 millimeter snare from Boston.
And you get by the endoscope out, or you pull the stent inside?
Of course. It's a 10 French, 5 centimeters. So we take the scope out and take the stent outside.
Okay.
Okay?
Okay.
So now we will begin cannulation of the CBD. We will use an ultra-term Boston Scientific sphincter term with a jag wire 0035. So we will begin the cannulation now. It should be easy as just remove the plastic stent. So we will go inside slowly the papilla. You can push the guide wire push. It's going inside. It's going little luctoscopy. You see the image of the fluoroscopy?
Yes, fantastic.
Okay, we remove. So now I think we cross the street. We can see on the fluoroscopy the CBD, the air in the CBD. We cross now the street. It's okay.
Can you enlarge the screen? Can you enlarge the fluoroscopy?
Can we allow?
Yes, the picture and the screen is not very clear. The video scope is very clear.
But
And you are very clear also.
we'll try to arrange it.
Yes, you can enlarge it. You can enlarge it.
Okay. So we are arranging this. So now we
Okay.
are in the CBD. The next step is the opacification to see level of the stenosis and the length exactly. So we will push the sphincterotomy in the upper CBD. We are inside. So the purpose of the opacification is to determine which stent we will use. Today we have a 2 stent. So the wall stent partially covered one, 6 centimeter, and the other one is an uncovered one, 20 millimeters. The purpose is to not cover the cystic duct.
Now there are Dr. Sami.
Yes.
It's a difference between covered and partially covered and non-covered now, because there is many lectures about the partially covered has no problem, the cystic duct. What's your opinion about that?
So for me, for this patient, I
Yes.
think the uncovered one will have less patency for recurrent biliary obstruction.
So
but
you
in the other
will
hand,
use-
we will have
you-
less cholecystitis, and the disadvantage of the uncovered one is more sludge formation, ingrowth tumor, and less migration. So for the covered one or partially covered one, it's known that it's associated with more cholecystitis, more migration, but longer patency. So in this case, the cystic duct is really near the tumor. So I don't have idea until now where it is now. So we will do the pacification. Is it okay for the fluoroscopy there?
Yes,
It's
yes,
okay?
very good. Yeah.
Did you see the fluoroscopy now better or no?
Now we see the video scope now,
But not
if
the.
we take the, we have only the video. Yes, we see the fluoroscopic now.
Is it good for fluoroscopy now?
It is good. It's good.
It's good. Okay. So we will begin the opacification now. So inject. So we'll see the CBD now. The right and the left CBD. We go back. I don't still see the cystic duct. It's here. We see the cystic duct there. Okay. The tumor is here. We now see the level of the tumor. Huh? Does it feel good? Parfait, très bien. Feel good الفوق. Huh? So, did you see the fluoroscopy now?
Yes, we see, but we cannot see the common bile duct and the bifurcation, as you said.
So, we'll just move a little bit the scope.
Endoscopic view is perfect.
Okay.
But we need more focus on the X-ray.
Did you see the X-ray now?
We see the X-ray, but we cannot see the detail of common bile duct very. But the endoscopic view is very good.
Hoi, hier zit hem deze. We will zoom with the camera the scope. Maybe we'll see it better.
Talk us through. Just talk us through what is happening and what you're doing.
So did you see? No, you don't see, but you see the fluoroscopy.
Yes, it is clear. Yeah, it is clear with the camera now. Yes.
So, the opacification, we will see the left, right intrahepatic duct dilatation. I see the cystic duct is really near at this level under the scope. So we think in this case we won't be able to place a partially covered one. It will cover the cystic duct surely.
Okay.
You see the marker in the sphincter?
Je cherche.
Yeah, we get a rough idea, so we can see what you're doing. So carry on.
You see the cholangiogram or no?
Yes, to some extent, we can see the dye going in.
So,
donc, comment je vais rentrer ma présence?
Yeah. Carry on.
So did you see here? We have the cystic duct here.
Yes.
Did you see it?
Yeah.
So the tumor began from the scope. I think it's maybe 4 centimeter. We'll measure it now.
Okay.
So the way to measure the length of the stent you will need. Generally, we have 13 millimeter of the scope. We will have maybe 1, 2, 3, size of the scope to have the size of the tumor.
We lost you for a few minutes. It was 1 minute, but already now it's okay. You are in line. Very good. Very good pictures.
Is it okay now?
It's very good. It's very good.
Carry on.
So yeah, Are you okay for the uncovered one?
I prefer to use partially covered.
Partially
But
covered.
you are the expert. You do what you want. We are, me and Bandari, Dr. Bandari, we are only observe and comment. But you are expert. But Naima, but I don't know what is the audience. I think she's the audience can say. But for me now, because all the lectures speak about using of partially covered, it's more patency, and also there is no huge study of cholecystitis. This is some study, but do what you feel that is good now. This is my opinion. But partially covered may be good for long patency.
So we are all okay for the partially covered one, huh?
Yeah.
This is my opinion, but this is not me the right one. This is my.
So, Dr. Sami, we have 5 more minutes left. So
okay, we will begin.
Show us what you're going to do.
Okay. برا دز فيكي دز شكون يحل بروتيزا مالكم؟ ماهر لا 10 هاي غادي عندك.
You have a very good nurse. Who's assist you?
A lot of nurse.
No. Who's assist you now?
Who assist me? It's Haifa.
Haifa, it's very good.
Haifa and my friend Usama here.
It's very good because she's working very quickly, and she will try to put us as a metallic stents also very quickly. So we enjoy that. I think you have still 5 minutes or 4 minutes, but you can do that. Your stents.
So for the metal stent, it's a wall stent, partially covered one, 6 centimeter and 10 millimeter diameter. We will have the 3 marker, the upper one, the lower one, and one in the middle, the point of no return. I should die.
Very good, Haifa. Very good. Yes, I need.
So we are going now with the stent.
Yes. The guide wire coming from the side.
So the stent is going inside the scope now. We push it slowly, gently.
But the guide wire coming from the end or from the side?
The guide wire is still inside. Same thing.
Okay.
Okay. We are now in front. The stent is outside. We turn the big wheel to let the stent inside, and we push slowly. Slowly. Did you see the video? It's going inside. The ERCP is here. We see the stent crossing slowly. The stricture. You see the marker, the upper marker now.
Yes.
We are here. We're waiting for the lower marker.
You depend on the area now. Sami, you depend on the X-ray or an endoscopic view?
Really, I prefer the video view. I will just focus on the lower part of the stent.
This is very important, that you look for the lower part of the stent, not to migrate
now I
inside.
see in video the lower part of the stent. So
very clear, very clear.
We have 2 minutes for... We will begin. Go. So now the nurse will push the stent outside, and I slowly focus on the video and take back the stent. So go. I'm with you. Go. Open. Slowly. We see the part, lower part. There you go, just inside. Go. Open. I focus on the video. Open. Still. Open. It's okay. You see the part. Open. I'm with you. Open. It's okay.
Excellent.
So the purpose is to have the stent 1 centimeter outside the papilla.
Beautiful. Very well done.
So we see in the endoscopy view now.
Yeah.
We have to remember that this stent will shorten a little bit. So I think.
Are you going to pull it out a little bit then?
Maybe, I think, yes.
Yeah.
But he will shorten a little bit. I think he will be in the maybe 2 centimeters lower.
Okay.
So I will leave it now as it is. It will be shorter.
It is.
Yeah.
I think it is good. It's good, Dr. Sami. It's a very good presentations. Very good team. I think they are working very good. Very nice demonstration. Also, very nice in the spot pictures. Very nice stents. Thanks to Fuji and Boston's and ERCP. And to your team.
Thank you to everyone here.
Haifa. And then, thank you. And then now we will move from Sudan, Morocco, and then we go to Algeria.
Hi.
This is my friend,
Hi.
Professor.
Hi.
Hi.
How are you?
I miss you. Yes. How are
Thank you.